I am excited to introduce you to Dr. Jacob Kariuki, who is our speaker from the School of Nursing. He's an associate professor and currently the assistant director for research of the Lillian Carter Center for Global Health and Social Responsibility. And Dr. Kariuki came to us from, the University of Pittsburgh School of Nursing, where he taught for 6 years prior to joining us last November. And we were thrilled that he was coming to Emory to share his expertise. He graduated with his PhD in population health and health policy from UMass Boston prior to that. And his program of research focuses on cardiometabolic diseases in high risk and underserved populations. And his research is well funded. He's received over $1.2 million from NIH and foundation grants. He's currently working on an R56 and has some exciting work through the American Diabetes Center and the Georgia Center for Diabetes Translational Research pilot. So we're excited that he's funded both nationally and locally and is joining the diabetes research team. He's presented his work widely, both locally and internationally, and at the American Heart Association, as well as American Diabetes Association annual scientific conferences. So before I turn it over to Dr. Kariuki, I just want to also mention that the Georgia Center for Diabetes Translational Research will be having another call for pilot grants for this year, and we will be sending that out sometime this month. So please do watch for it. The deadlines are for the actual grant is February, but we'll have a letter of intent prior to that. So please do watch for that call for the pilot grants. And so without further ado, let's hear from Dr. Jacob Kariuki on the obesity-inactivity vicious cycle, something important to all of us and the patients and clients that we work with.
Thank you so much, Sandy, for that great introduction. And I also want to appreciate all of you who came here in person and all of you who are joining us on Zoom. I'm going to go through the presentation quite quickly so that we can have more time for engagement. But if you feel like I'm moving faster than I should, feel free to interrupt me and tell me to slow down. These are the objectives that I hope, if I am successful, we should be able to cover the 5 bullets that I have highlighted here. You're going to appreciate them as we move along. So when we talk about obesity, a lot of people look at this clinical phenomena like a simple energy balance issue. And in a lot of cases, when we give clinical or even research recommendations, we kind of seem to suggest to people that if only they eat less and exercise more, the issue is going to go away. But we know it's not that simple. The obesity phenomena is complicated. There is a lot of genetic, hormonal, and environmental underpinnings that we've not even fully understood. So I want you to remember this when we get to the kind of recommendations that I am going to highlight, and also when I will be discussing some of the work that we will be doing. Why should we care about obesity? If you look at the global prevalence of obesity, we have 650 million people with obesity today, and in 2 years, this number is projected to hit 1 billion people with obesity. And we know that when people get obesity, it's a big problem for healthcare systems. And a good case in point is here in the US, 4 out of every 10 people that you encounter are struggling with a problem. And this issue has been increasing year over year. As you can see, 30% in the last 2 decades. And you see the same trend among children. And the healthcare systems are definitely overwhelmed because almost every condition that you can think of, obesity may have a role to play in either it's evolution or it's exacerbation. So this is a very, very big problem. You cannot address any of the chronic conditions that I've highlighted here and many more without having to deal with the reality of obesity. And we know that not all obesity is created equal. The degree of obesity, like people with class 1 obesity, their problems may not be as big as people with class 3 obesity. The duration obesity has been in existence also makes a difference. And also something that we do not talk about so often is also the distribution of the fat. Where is it? And we are going to highlight some of those issues. Back in 1999, Carl and colleagues did a very, very nice analysis, and they came up with this graph that highlights a J-shaped relationship between obesity and mortality. And I want to highlight a few things here. Low risk, when we get to the overweight phase, we see the relationship is not that strong compared to when people get to the obesity cutoff point. And we know that when people are in the overweight area, the location and the distribution of the fat is actually one of the greatest determination of how the association with mortality looks like. People with a lot of upper body fat and belly fat, the mortality rate is higher compared to people with fat in the lower parts of the body. And this realization that, the fat distribution is going to affect the outcomes has led a lot of people to put a lot of emphasis on body composition and waist circumference. But there is general consensus that when people get the obesity phase or track point, we really need to do something on their weight and on a lot of other outcomes. And if you look at the current approaches, I call them weight-centric, although that's quite unfair, a little bit biased, because people who initiate them are not always looking for weight. But when you talk to the general public and people who engage in a lot of the interventions, they remember one thing and one thing only: I'm here to lose weight. And if you look at this, in yesteryears, a lot of people focused on food quantity, restricting the calories. People are doing a lot of counting, and then the dietitians came up with even better ideas of focusing on the food quality. You can eat more veggies and fruits and, plant-based diet. And then you had the surgical operations. In many years back, people used to do a lot of liposuction. They didn't work very well. Nowadays, we have more effective strategies for helping people reduce weight, and a lot of pharmacotherapeutic initiatives. Things like Ali have been there for a long time, helping people reduce their absorption of fat and all of that. We have the new Ozempic, everybody talks about it, doing magic, and then when you thought that the science was settled, you hear about all of these complications, right? You are having a lot of paralytic periods and other complications that are making people wonder what the long-term implications are going to be. All of these initiatives are great, and I think they do make a difference, especially in helping people who need to lose weight, lose a good chunk of their body fat. But the problem becomes if the messaging is only focused on one main metric. You're doing well when you're losing weight, and you're not doing well when you're not losing weight. We end up in the situation that all of us are so much familiar with. People come to us either to the clinic or to our research studies, very excited about what we are promising we are going to accomplish, whether it's a new drug, whether it's a new behavioral intervention, or even a surgical intervention. And then in a lot of cases, a good number of people do not even attain the primary goal of the intervention. And those who do, they are not able to maintain the weight loss. And that leads to a lot of frustration. And when people are not seeing that number go down, what they do is give up. And you see a lot of regain, and the weight goes way beyond where they are in a lot of cases, even where you found them. And then the obesity prevalence and the degree of obesity keeps going up, and we keep repeating the same cycle over and over. You meet a lot of people who are very frustrated, clinicians who are very frustrated, and investigators who are not able to show that their interventions are going to work. And I'm going to share some examples of interventions that we've done where after spending over $3 million, we can make very much difference when it comes to weight loss outcomes. This is very, very frustrating. And everybody is looking for a way to break the cycle. I don't promise to present anything new. The only thing that I want to do today is to bring to our attention some of the obvious things that we ignore that can help us lessen the burden that we impose on clinicians and investigators and make the lives of people who come to us for help easier and give them pragmatic goals that they can accomplish and maintain. I don't have the bandwidth or the time to talk about nutrition, so I want to dwell on the energy expenditure part of the obesity equation. This is something we know, but we rarely talk about. It is very, very difficult for people to lose weight exercising. And I want you guys to look at the table that we have here. If you have a 300-pound man exercising an hour a day, they're just going to lose about 450 calories per exercise session. So you're talking about 2,500 calories in a week. And by the time you make this person move like that, and they are moving at 3 miles per hour to be able to accomplish that, it's very daunting. Very few people can be able to do that. And if you look at the guidelines, they do not lie. They put it very, very clear. They say that, hey, for improving health, you can do the 30 minutes a week, 5 days in a week. But if you really want to promise weight loss, you really need to notch it up, go to the 300 mark. And from the reality, we know that people who really need to do this, people who we are telling to do a lot of this, they barely do the 150, right? And we also know that these are not the people that you're going to find in gyms, putting in the work. And there is a lot of factors influencing that. If you try to come up with a physical activity intervention, you're likely to recruit people who are already doing a lot on their own. And when you put in a lot of work to recruit people who struggle with obesity, these are the people who are very quick to drop out from the study, and when they remain in the study, in most cases, they do not adhere to the intervention. So this is kind of a very uncomfortable reality, and you will see that if you take a closer look at a lot of meta-analysis focusing on physical activity, and you look at the populations recruited in these studies, you will see a lot of bias towards people with normal weight or people who are slightly overweight. And actually, I would recommend all of you take a look at this very thoughtful article by Dr. Kariuki. He's talking about the mysterious case of public health guideline that is almost entirely ignored, and he discusses the extreme avoidance of physical activity in obesity. And there is a lot of reasons to that. A very, very insightful review that they do. And this is where this leads us. You have people with obesity, and we know that obesity is associated with a lot of chronic comorbidities. And when those people become inactive, and we know that physical inactivity is associated with over 35 chronic conditions. So if you combine obesity with physical inactivity, you're compounding all of these problems. And we get to the business of what comes first. Is it inactivity or obesity? I don't want to get into a chicken egg argument, but we know that when you fight these two conditions together, it's a big, big problem. And unfortunately, we do not have a lot of physical activity, large physical activity studies which use accelerometers. A lot of them are self-reported. So bear with me for using some dated data. But this was like entrance 2003 06 cycle. You can see a very linear thread. The higher the obesity, the higher the BMI, the lower the engagement in physical activity. So this is a problem that we all have to deal with. And how do we react to this? I don't want to, this was 1994, way back, but the famed nutritionist, he made a very interesting claim that the contribution of exercise to the treatment of obesity is trivial because people with obesity are unable to do much exercise. A lot of times we make those conclusions even without articulating them. We know that, hey, this is a physical activity study. I am not going to put much effort recruiting people with these high BMIs because I know they are not going to do very well in the study. Is it so? Must it be so? Is there anything that we can do to make sure that these people get the activity that they need? Because we all know that they need exercise probably more than any other clinical population. And I want to share with you some lessons that we learned for the junior faculty. I will really encourage you to always talk nicely to the senior faculty with R01s, another grant where you can get an administrative supplement. Doesn't cost you a lot of effort, but you get a lot of opportunities to learn from the best and also for you to do your own small studies within the R1 framework. So I did a supplement with this amazing study. It was an R1 where we recruited 502 people. And the title of the study was, of course, what we all do, weight loss. And there is nothing wrong with it. We used a lot of technology under the leadership of the amazing Dr. Robert Park. So everybody was getting a scale and diet monitoring using Fitbit. We were also tracking physical activity using Fitbit. We had our own app that gave tailored feedback messages to the participants based on their self-monitoring data. And if you look at the head of the study, this is what the results look like. People are losing weight all the way to month 6, and after that, they start gaining weight. And this is not unique to our study. A lot of studies have shown this over and over. And this is where I came in. I organized focus groups where we invited people who did well in the study for their own focus group, and people who did not do very well in the study for their own focus group to figure out what worked for them and what did not work for them. And as you can imagine, people who did well in the study, they were the easiest to get to come to the focus groups. And they had a lot of great stuff to talk about. But these are people who were already doing quite all right, or they had some, more favorable characteristics at baseline that made them predisposed to doing very well. And people who didn't do very well in our study, as you can imagine, the demographics would have been different. But these are some of the comments that we got. Some people actually thought making them weigh themselves daily was not even good for their mental health. And look at the reason. It's not because the scale was painful to step on. It was because of the number. It's not moving. And you had another participant who was saying, like, I was sticking to the exercise goals, eating 1,200 calories in a day, and I was super unhappy for not losing weight. And, look, within a month, they had given up. Why would they give up so quickly? We know that miracles are not going to happen within a month. But why did they give up? Was it because there were no actual benefits they were accruing from, them doing the right thing, changing their lifestyle? No, we know that there is a lot of other benefits, but when we do not communicate them very well, people have to deal with what they are feeling right away vis-a-vis what we promised them. And we know that when people come to an physical activity program with very high BMI, one of the immediate things you're going to feel, even people without very high BMI, if you've not been exercising for quite some time and you start a more intense workout, you're going to lose breath and go through all of this. But if you have more weight, the pain that you get, especially in the initial days, and if your activities are not very well calibrated to be very slow in intensity, people are going to look at this and say, like, why am I doing this? Why am I starving myself and aching my body over and over, and I'm not seeing any results? And you get into this vicious cycle that we've been talking about. People associate physical activity with pain, and they avoid exercise. They go to their doctor, or they see a study, they get excited, they try again, they fail, they do not get what we promised them to get, and it becomes something that is very unpleasant to them. And this is one of the contributions of the extreme avoidance of exercise in obesity. And I am here to suggest to you that instead of following this weight-centric approach, which we know does not really work, because there is a lot of physiology behind people gaining weight, even when they continue doing the right thing, right? Weight cycling is a phenomena that a lot of papers have been written about, and we know that we will never have a very clear-cut weight loss strategy until we understand more about the key drivers of obesity. And I'm proposing a less burdensome approach, which is not new. We all talk about it, but in a lot of cases, we do not implement it in our interventions or even in clinical conversations with patients, focusing on what we are calling a neutral approach. By saying weight neutral, we're not saying like, hey, weight is not important, don't even talk about it, but not putting the weight at the very center of the interventions and focusing on the health benefits. And I cannot lecture you about the benefits of physical activity. We have the immediate benefits, things that people start feeling and experiencing as soon as they change their lifestyle. And I know some people say like, this is not going to work to a lot of people because, they care about weight. Someone said that what we see depends on what we are looking for. When we enroll people in a study or we engage them in a clinical conversation, and we put a lot of emphasis on them watching for that important weight goal, they are going to discount a lot of other benefits. They may not even see them because they're not looking for them. But if we can, be very realistic with them and give them realistic targets, depending on what their needs are, you're likely to see more engagement. We can talk about immediate and long-term benefits, and we know the mechanisms through which physical activity is driving all of these benefits. We can actually share them. We can include these mechanisms in grant applications because, we have to make justifications why we are giving all of this guidance to patients. And Glenn and colleagues, a couple of years back, they actually did a very, very nice review that tried to show that the obsession with weight sometimes fails to see the actual point. If you look at this data, the risk for all-cause mortality, look at this. People with more optimal or higher cardiorespiratory fitness, they are faring way much better actually compared to people who are less fit when it comes to mortality risk. And the same thing applies to people with obesity who have cardiorespiratory fitness are doing much better than people with normal weight with very low fitness levels. And we know that when people exercise or engage in physical activity, even when they are not losing weight, one of the quick things that you can improve is actually cardiorespiratory fitness. And this is something that we can measure. Of course, I know a lot of people say like the actual measurement of the cardiorespiratory fitness will require very sophisticated, expensive equipment. We do not have the clinical resources for doing that, but there are a lot of other proxy measures for measuring the fitness, like the YMCA step count. Some people even do like the 6-minute walk to kind of give you an idea of where people are. But generally, and this is more so for studies, a lot of investigators, we need to be thinking about shifting our focus to put more practical and realistic metrics when it comes to evaluating the efficacy of our intervention. And another thing that people do not talk a lot about is body composition. We know that when people exercise, their bones may become stronger, they may have more muscle, and BMI is a very damn measure, right? It talks about any mass. It doesn't matter where the mass is coming from. And I like this chart because it gives you a very nice picture of what is going on. If you look at the BMI, you see the J-shaped curve that we talked about earlier. This seems to correspond with the fat mass index when you look at where the fat is. But when you look at the fat-free mass, it seems to be doing quite well and actually declining for people over the age of 65. So the more mass, fat-free mass people have, the better it is for them. Of course, for people over the age of 65, when they have more fat-free mass, you're seeing it means they have more muscle, which is good for them in terms of protecting them from frailty and other complications that are associated with age. But this gives you a very good picture of if we focus on things that are going to make more sense and things which are likely to be more attainable to patients and participants, maybe we can give them hope. We can make them get engaged and remain engaged instead of focusing on a number that we know does not even discriminate where the weight is coming from. And as a quick illustration of what we did from all the lessons that we've learned from the other studies, we actually designed our own intervention that we intentionally intended to be weight neutral in terms of the way we engage with the participants. So I'm not a qualitative researcher, but before developing an intervention, I always like running the thoughts to the target population. So we did some focus groups. We designed the intervention based on the feedback we got, and then we did a testing of the technology to see whether it's going to work with the population, and then we did a pilot study. This is what we learned. The people who came to us with obesity, they were looking for something convenient, something they could enjoy doing, not push-ups and all of those punishing sit-ups that we tell people to do. And they also wanted to do it in a comfortable setting, places where they did not feel judged. They said, like, if you go to the gym weighing 300 pounds, all the eyes are going to be on you, right? And then you do a 5-minute treadmill, you're losing your breath and everybody's almost calling 911 on you, right? They stay away from all of these places because of judgment. Of course, it's not like people are horrible. It's only like this is a phenomenon that we do not encounter often, and people are not very sensitive about what is going on. People are also looking for diversity. And for many years, a lot of physical activity interventions featured very skinny white women exercising, right? You didn't see a lot of people of color. Over the years, they have improved that. So people told us they wanted to see diversity, but not only in ethnicity and all of that, but also in body shapes. They wanted people who struggle exercising, talking to them about exercise, not people who are telling them to move their legs in places they will never go. And also age. People who are older were not very well represented. And realistic messaging. And this is what we did. We leveraged open source resources to look exactly for that. If you look at this snapshot of a video, you can see diversity here, you can see body shapes, and more importantly, the messaging. We were looking for content that emphasized health instead of skinny. Some of the women who came to our focus group told us, I have made peace with how my body looks like. I know I'll never look like that skinny, little girl people keep pushing me to look like. So if I want to engage in physical activity, it has to be for something more than simply losing weight. And this is what we did in our beta testing of technology. We wanted to know the devices people are likely to use when they enroll to log in our platform, whether our URL is something people could remember, were they going directly to it, or they have to do Google search, how long they were spending on the site, and whether our messaging, automated messaging was working. And after we did that, we optimized our platform. This is how the dashboard looks like. Of course, we are doing a lot of upgrades with recent funding. So we were able to give people recommendations. So the coach would push these workouts to a participant, but the participant could go to the library and choose something else within their fitness level, and they would tell us what their favorite workouts were. And eventually, we interfaced the physical activity tracker with our platform. And the reason was very simple. We didn't want to have people watching our videos, eating popcorn, and then we are thinking they are exercising. So we were able to plot for them like, okay, these are the videos that you're using, and this is the kind of activity you're seeing from your tracker. And we screened 492 people over 6 months, enrolled 32. And I want to highlight, we had very good retention. We only lost 2 people in the intervention group for non-study related problems, and 1 person in the control group. When she realized she was not randomized to the intervention group, she just quit. If you look at the diversity, very diverse, and this was a big accomplishment at Pitt. Pittsburgh is not like Atlanta. Adherence to the coaching, 96% of the participants attending at least 5 out of the 6 sessions. And one of the main drivers was the conversations were never focused on how much weight you're losing. It was, are you moving, and can you continue moving? The physical, people who do web-based intervention, they know that the first 2 weeks you see a spike, and then after that, nobody even remembers the password. We were able to see continuous engagement with the intervention. It was a 12-week study, so we cannot make big claims about all of it, but we were very impressed by what we saw, the number of visits, and also the engagement. We got over 2,000 comments on the workouts and a lot of ratings on the videos. When we did ask people what they really liked, the workout videos, and people had a lot of great things to say. I can see myself in that second woman there who was losing her breath in minute 3. So the people had a lot of appreciation in the messaging in the videos, and the people who are involved in it, the tracking, being able to see how they are progressing over time, and the convenience. If you think about the people that we had, these are people who are shift workers. They don't have a regular schedule for going to work. They may be off at midnight. They could simply log in and do whatever they needed to do at midnight. Of course, we got a lot of good recommendations for things that we needed to improve, especially the interface with some of the technology that we were using was not as good as it could be, and we are working on all of those. This is a very good sample of the kind of interaction that we attracted or we requested our participants to do. Every time they chose they clicked on a video, we would ask them to rate it after using it. Is it a 1-star or 5-star? And then tell us how difficult it was for them to use it. Because we know that as much as we talk about, hey, this workout is a 2-minute, 3-minute, the intensity of activity is dependent on, the BMI of the participant and baseline and their fitness level. So the coaches did not give them more intense workouts until they were sure that they were reporting lighter perceived exertion with the initial category of the workouts that they got. And I want to highlight, this is the feedback. Everybody could write or comment on the video they used. They could not see each other's comments so that they don't influence each other, but we could see all of them. One of the things that we kept seeing from the videos was, I appreciate a leader who is not a quintessential body type. And I think we discount that a lot, and how something simple can make you feel better. You will see in the messages that we got, rarely did you hear anybody talk about weight, because we primed these people not to focus on weight, but to focus on wellness. And our conversation used to be, we all know, you don't need to tell anybody out there that physical activity is good for them. So we tell them, we all know that physical activity is good for you, but your body decides how to respond to physical activity. For some people, they sleep better. Some other people, their mood is going to improve. Other people lose weight, not a lot. But the key thing is to keep doing what you have control over, and let the body decide how to do it. And I want you to look at our daily step count. You will see that in the intervention group, we continue seeing improvement. We got about 1,200 daily improvement in step count, which does not really look super amazing. But if you look at our MPPA, we were able to get people to almost 59. And the reason why you see the difference in step count, we get a lot of different kind of workouts, core workouts that did not require people to be jumping up and down. And people were gravitating towards, some people are doing walking only, but a lot of other people are doing some really jiggly dances that required a lot of movement of upper body, but not really the legs and so forth. And we also saw significant weight improvement, about 3 pounds. Not really great, but we were not even looking for this. And of course, a trend towards systolic blood pressure improvement and all of that. We did take the A1C and all of others to kind of pilot the possibility of doing remote blood sample collection, but we did not expect a change. This is what we're doing. We got about $500,000 from NIH to improve the technology of the platform. So now we are adding some content focusing on diet quality so that we can be able to use that. We are also optimizing our machine learning system. So when people tell us, like, I like this video and I like this video, we've created a machine learning system that goes back to the open platforms where we are getting these videos and looking for new content that we can continue adding. And also, we've made it possible to be able to run multiple concurrent studies on the platform. And we are also exploring behavioral mechanisms that could explain the changes that we are seeing in physical activity. And we are also collecting some biomarkers, which are more proximal and amenable to physical activity. So there have been a number of studies showing that when people start exercising, especially people with very, very high BMIs, you may see a lot of changes in cytokines and inflammatory markers, which are, if you improve them, you are actually doing a lot to prevent insulin resistance. So we will be able to demonstrate that. This is the machine learning system that we're using. It's becoming more and more efficient. And this is our recent funding. Very, very excited. If you look at what we got from the ADA, we are looking at the most popular workout within our platform: walking, dance, and core workouts. And we are trying to look at how they are going to influence for cytokines for individuals with obesity. We have another study that we are doing in Kenya. And then we have a grant under review with some colleagues in Orlando, trying to look at how remote exercise is going to improve cardiometabolic and brain health in early life adversity. The individuals exposed to early life adversity In the grand scheme of things, within a year, we want to apply for an R1 to do a large efficacy trial so that we can be able to make some really good claims about the capabilities of our platform. We are also looking for opportunities to collaborate. So if you're a person who is interested in working with us to explore how all the data, remember we are collecting a lot of data from the wearable sensors. And we are also collecting a lot of data using our website, the analytics, which videos are they using, which ones are they rating, and when are they scheduling their activity. We are looking at ways in which we can explore how we can use that data to guide exercise prescription, when to prompt them to exercise, and the kind of recommendations we should be giving them. And also, lastly, if you have an intervention that requires a physical activity intervention, we will be very, very happy to have a conversation and explore ways in which we can collaborate. Thank you so much for your time. We have about 17 minutes for questions. And for people who are on Zoom, you can unmute yourself and simply articulate your question. Yes.
Yeah, thank you very much for the presentation. I like the idea of separating the desire to lose weight from exercise, because exercise is good regardless of weight, and people may be more motivated.
Yes.
You think that once people do exercise without thinking of the weight, they may be more motivated to have a healthier diet, and then indirectly lose weight, not a direct effect of exercise, but exercise exercise promoting better diet. So diet is a mediator for the exercise to promote loss of weight. Do you think it's something that you think to test this?
Thank you so much. That's a very, very good question. And for people on Zoom, he is asking whether it's plausible that if people are motivated to continue exercising without really focusing on weight over time, they may actually take initiatives to improve their diet, and then you may see exercise mediating improvement in their nutrition. Is that your question?
Yes.
Yes. So I would say it's very plausible. We've not collected any data on that, but anecdotally, a number of people who we included in the pilot that I shared with you reported to us that, hey, when I realized how great I'm feeling after doing these exercises, I stopped taking a lot of junks. One of the things people usually stop doing is doing a lot of Coca-Cola. We got people who are taking a lot of soft drinks come to our study, and they, without even us not talking to them about it, they would take the initiatives to stop. So I think it's very plausible. But I don't know whether I've seen any studies systematically studying the phenomena, but we know that it's something that a lot of people may get into. Very good question. Yes.
Yeah, just to talk a little about it, I think one of the mechanisms why this happens is because when people don't feel good about themselves, there are a lot of negative emotions involved in it, and like junk foods, we know that are really related with people feel bad, so they will eat something that is pleasure to feel better. And sometimes when they engage in something like physical activity, not to lose weight, but they feel better with themselves, maybe they don't need anymore this kind of behavior to deal with it. Yeah. So I don't know, just something that I thought here, like
self-efficacy.
Yeah.
If the person believes they can exercise, they also believe. And maybe they don't want to drink on Friday because they have to run on Saturday, so they lose weight indirectly.
Wow, those are very astute contributions, and I think they are very plausible based on what we know about nutrition. A lot of weight issues and food issues that we see are actually driven by behavior. There are people who, when they are frustrated or depressed, one of the things they do is eat and eat more. So I think there is a lot of science actually showing that when people feel better, they are less likely to engage in some of the binge eating and other things that people do. But I think those are great ideas for studies. We will definitely try to maybe collect some data on what people are doing without even us prompting them. Yeah.
I think that's a good idea, Jacob, to get some kind of tracking, because I wonder about the sequence of things. Like, you're not focusing a lot on diets per se in this study, but if people, the sequence of introducing diet or exercise or simultaneous. So that's kind of one question, is what do we know about that? And then second, what are you doing about stress and measurement of stress and the whole notion of increased cortisol and its contribution to fat distribution and weight and management of that as well?
Very, very good question. I think starting with your question number one, what do we know about the sequence? We did a systematic review, but I promise I will never do another systematic review in the next 2 or so years. It took us about 4 years to get it done. But one of the most interesting things that we observed was studies that combined exercise with diet. In a lot of cases, our primary outcomes were change in absolute cardiovascular disease risk. They did not achieve that. But studies that did either achieved that. And I think there have been quite a number of conversations about that. Maybe because both of the behaviors might be too complicated for people to deal with them at the same time. Maybe it could be because of the focus of the studies. I think there is a lot of variables to that. And there is a lot of room for us to study the sequence. Should we initiate both together, or should we have like a staggered sequence? We get people on track for one thing, we get it very good at it, and then we introduce something else. I think there is a lot of room for us to study the sequence and what may be ideal for certain demographics, because there's no one size fits all. People come with different needs, and they may need to start at different points. In terms of the second question had to do with stress, yeah. So we are already collecting self-reported stress using the NIH tool for stress. We've not analyzed that data yet from the previous study, but one of the things that we are considering doing is actually starting to look at the hair cortisol levels. That is a very interesting avenue, because we know that especially the minority populations that we recruit, there is a lot of data showing that cumulative stress is a big contribution to the obesity phenomena. Some of it driven by the dietary habits that people adopt when they are frustrated and stressed, and some of it actually driven by the cumulative effect of cortisol in their system. So yeah, those are very important data points that we will be interested in looking at. And this is where I'm saying, like, hey, if you are interested in collaborating, we are open for business, because when you are a relatively junior faculty, you don't have like an army to help you be looking at all of these data points. You're only looking at one thing at a time, writing papers and doing a lot of other things. So if you have students or other faculty who may be interested in working with us on these questions, we have the data.
Thank you. That's great.
All right. Yes.
Hi, Jacob. I'm sorry I couldn't make it in person, but this is Foster. And I now understand why everybody keeps saying, have you met Jacob? Have you spoken to Jacob? And I am very interested in this, and you already know, but I am also interested in the fact that in the role of neighborhood and the lived experience in this diet and physical activity intersection, right? And so looking at the way previous experiences or early childhood experiences with dietary behavior influences choices during adulthood. Do you think we could probably work something together with that? And even looking at how Sandy was talking about how we introduce physical activity and diet, either at the same time or one after the other. Because one of the studies I've been involved in at NHLBI, we did randomize participants into physical activity tailored to their neighborhood. And I think we can actually work together on modifying or merging how we look at physical activity and diet to address the sequence piece and the lived experience, in addition to how the pathway of stress in all of that.
Thank you, Foster. I'm not an expert in anything diet, but I work very closely with nutritionists, and I think they would concur with you that, lived experiences and people's childhood experiences do influence a lot of the choices they make later on in life, and there is a lot of opportunities for primordial interventions to address that. What I can speak to is the impact of neighborhood walkability on people's ability to exercise. And I'll tell you this, based on one, clinical experiences. There was a time I was doing some work for Humana health plan in New York as a nurse practitioner. So we were doing like what we call annual wellness visits. And I would go to Queens and Brookline and talk to people about, hey, what are you doing right? We go through all their medical records, what they're doing right, what they need to change. Every time I talk to people about exercise, hey, do you really get out and do some exercise? They tell me like, are you crazy? I don't go out unless I really need to because of neighborhood safety, especially people in low income government projects. The risk of getting shot was so high that they thought, and in a lot of cases, it's not even based on hard crime statistics, it's perceived safety. People felt like they didn't need to go out and exercise. In the SMART study that I did at Supplement on, one of the things that we got from the participants in the focus group was, your messages were great, but when you're telling me to go out and take a walk in the park, we don't have sidewalks or a lot of open space in my neighborhood. What am I supposed to do? And in one of the papers that we wrote, focusing on neighborhood walkability, we suggested a very low-lying fruit for people who are developing physical activity interventions. Neighborhood walk score is something that you can quickly get from the walk score company for free. If you go to places like Zero, even when they are advertising houses nowadays, they put like the walk score for the house that you're buying. And that can help you when you're talking to people about what they need to do to kind of have an idea of the resources that are likely to be available to their neighborhood. A more comprehensive approach is like what we've done. We've created an intervention that people can do in their own homes. We don't call it a substitute to what they are already doing. This is to complement. So if you're walking only one day in a week, we give you a 15-minute workout to increase your activity by 15 minutes. And we can increase it over time based on how you do it. I think we have one more question.
It's more like a question to see what you think about, but when we think about physical activity, we think about just not two constructs, but I think that is like we have physical activity levels and sedentary behavior. And there are some studies that say that both of them are independently associated with health-related outcomes. So in your study, you are looking mostly for moderate to vigorous physical activity levels. But do you think that maybe it's possible to add to it some kind of messages to try to reduce sedentary behavior, like, because in terms of feasibility, it's something that is kind of very visible to do, like messages like, oh, every 1 hour you're sitting in your work, you how do I say? Get up and walk around. Yeah, that's it. Sorry for my English, but that's it. Because I have done lifestyle intervention, behavioral intervention, with these three constructs like eating, increase physical activity levels and reducing sedentary behavior. And I saw that reducing sedentary behavior was one of the most simple ones for people to achieve. So I don't know, just counts.
And I think you're making a very, very important suggestion. There is a lot of room for improvement when it comes to the physical activity spectrum. If you can figure out a way of breaking sedentary behavior, I have a colleague who is doing an R1 where they are focusing on breaking sedentary behavior for desk workers. They have like a Fitbit that buzzes them to like, can you start and move around for a few seconds? Not even intensive activity. And that's one of the promising studies. Of course, it got one funding. I also attended a AAHA conference where I remember one of the presenters was actually talking about their intervention to reduce sedentary behavior by asking people to sleep more. Think about it. So if you look at a lot of sedentary behavior, it's people staring on their TV late into the night. And instead of telling people to exercise, especially when people are really struggling with a lot of other issues, a very low-lying fruit, how about sleeping for 7 hours instead of 6? Do you know that you're reducing their TV screen time by an hour? And that's one of the studies that I'm really looking forward to seeing the outcomes, because it makes a lot of sense. We know that good sleep is going to make people have better mood, and when people are feeling better, they are likely to exercise, they are likely to eat less. So I think the challenge we have is the behavioral world. We operate in a lot of silos, because I'm the physical activity guy. I don't even look at sleep outcomes. I don't even collaborate with sleep people. So what we are doing in our study right now, we are also collecting sleep data, both using questionnaires. So I consulted with one of the sleep folks I used to know in Pittsburgh. So they recommended 2 questionnaires for sleep quality and dimensions. And we are also collecting sleep data using the wearable tracker. And the reason is what you're simply alluding to. There are so many ways in which we can slice this problem and find a solution to it. Good observations. Yes.
I have 2 questions. First, thank you for such an engaging presentation. My first question was, were you able to see any differences of those who were perhaps like class 1 obese versus class 3? I know that at the beginning of your presentation, you mentioned how, perhaps even the attainability of like 100 minutes per week, physical activity might deter people from even engaging in physical activity at all. So I was just wondering if in the group of individuals that you looked at, were there any individuals who perhaps would, maybe class 3, like obesity versus class 2 versus class 1, and to see if there was any differences. And my second question was, I work with the diabetes division of diabetes translation at CDC, and one of the things that the huge promoter of the National Diabetes Prevention Program, which is a lifestyle change program and not a weight-centric program. So my question was, is there any way that you can present non-weight-centric metrics to, like some participants as they are after, they have engaged in the intervention, so that point after the 6 months, which we have also seen in the National Diabetes Prevention Program, there could be some sustainability afterwards.
Yeah, very, very good question. To question number 1, we've not really looked at the diabetes categories, but number 1, I think one man show, and we focus so much on getting the primary outcomes out, but that would be something to look into. Although we are limited by the small sample, when you have 40 people in intervention, there is very limited things that you can do with that, but that's definitely something we can explore. We will be looking into that because it will be interesting. The second thing is the kind of feedback we give to participants. To be on the safe side, because we didn't know how the dice is going to roll for the initial pilot study, we gave people at the end of the intervention, we told them we are going to set you a report of all the measures that we are going to make that you can understand.
So the first thing that we put in their report was the change in physical activity. So, and we gave them both the MBPA and the step count. So we told them like, we got people who are doing like 3,000, 2,000 steps in a day. And then we showed them how far they went after that. And then we gave them the blood pressure measurement. And I think we definitely can have a more tailored outcome, like a primary outcome everybody can be looking at, but the lowest lying one is of course change in physical activity, because we know that different people report very little at physical activity. And this is something that we are continuing to explore. When we put our first one, which came very close to funding, and then they gave us their 56, one reviewer was very hung up on why we are not emphasizing weight loss. And this is why when I came to Emory, I was very excited to be collecting more data on the cytokines, because we know that some of them are very, very sensitive to changes in physical activity. And you can make a very strong case that these are known determinants of insulin resistance. If you can show that they are actually declining or improving over time, there is no point of having a lot of back and forth about weight loss. And we're not discounting the importance of weight loss. Some people will really need to lose weight, but we're also saying that it doesn't have to be the front and center of every weight intervention. Thank you so much. I think our time is up. I really appreciate your time and engagement.
Thank you, Jay. Thank you.